All right, so this is just going to be a quick overview of some of the more common CNS inflammatory diseases, including the immune-mediated diseases and also the infectious diseases. But starting out with, we'll just go into an introduction on CNS inflammation. Remember that the CNS itself has very little in the way of an innate immune system. So first, we're just going to discuss how the white blood cells enter into the central nervous system. First is going to be by cell migration, and that's going to be done by adhesion. And this is a cartoon demonstrating the two steps in traversing the blood-brain barrier in order for neuroinflammation to occur. With respect to the blood-brain barrier, remember that we have the endothelium, the tight junctions, the basement membrane, and the astrocyte foot pros barrier 2. So in order for cells to get into the CNS, they have to cross all of these barriers to get into the parenchyma. Binding to the white cells occurs through a number of different mechanisms. And after the binding, we have a transcellular migration and then the full influx of the cellular response. Just a reminder of how much is going on for a cellular response to occur, and a lot of this is going to be occurring within the perivascular space, the Virchow-Robin space. So whether we are talking about infectious or non-infectious, when we have endothelial damage, this is when we have a release of pro-inflammatory cytokines. So we discussed the white cell entrance, but there are also times where there is increased permeability of the vasculature, which sets up a neurotoxicity cascade. Much of the following steps are occurring both concurrently, but also sequentially, where edema, and again remembering the different forms of edema, occurs, which can lead to an increase in intracranial pressure and subsequent decreased cerebral perfusion. Then on the other side of things, we get ischemic injuries, which leads to excitatory neurotoxins, with glutamate being the primary one often thought of, and ultimately this leads to a cascade of neuronal death. Along with the peripheral immune cells, there are resident CNS immune cells, the microglia. They originate from mesodermal hematopoietic precursors and are slowly turned over and replenished by proliferating in the adult central nervous system. In the healthy brain, resting ramified microglia function as supportive glial cells, and their activation status is regulated by neurons through soluble mediators and cell-to-cell contact. However, in response to brain pathology, microglia become activated. Acquisition of innate immune cell functions render microglia competent to react towards brain injury through tissue repair, such as with activation of interleukin-4 from T helper 2 cells or induction of immune responses. In certain pathologic conditions, however, microglia activation may sustain a chronic inflammation of the brain, leading to neuronal dysfunction and cell death, such as activation by tumor necrosis factor alpha by the helper T1 cells. This might be mediated by the microglia release of extracellular toxic reactive oxygen and nitrogen species. So just bringing home the point that there's the microglia, and they can either become helper or toxic. When we have CNS inflammation, we often won't have specific signs, but rather have multifocal signs. We can see forebrain and hindbrain signs, just pain from the meningitis, or stronger deficits from an encephalitis or a myelitis. If dogs have meningitis alone, then you can be fooled into thinking that it might not be neurologic, so just something to keep in mind. And you can also get multicranial nerve signs depending on the location and potentially systemic signs. Again, just bringing home the point that with infectious, it could be multifocal, focal, or diffuse. So trying to get clues to localize and develop differentials, A full examination, including extraneural signs, are important. A fundus exam can be helpful, for example, in a cat with FIP, where you can see engorgement of the optic vessels with a purulent appearance around the vessels itself and also the retina itself. Otic exams if there's concerns of otogenic bacterial meningitis, potentially a murmur if there's concerns of endocarditis. So just emphasizing the importance of being thorough. Now, often when we diagnose CNS inflammation, we have to go through a gamut of diagnostics. The most important are going to be cross-sectional imaging, with MRI being the best. Also, CSF analysis can be helpful with differentials. We always want to rule out infectious disease first before we make a diagnosis of a non-infectious cause. MRI is going to be the gold standard, and often you will see hyperintensities other than within the ventricle itself, which is indicative of pathology, often edema, which can be confirmed on FLAIR sequences. Lesions can be focal or multifocal and can be localized to the gray or white matter or within the meninges themselves. The difficult part is a lot of changes that are seen with inflammatory disease can be seen with neoplasia as well, or even vascular disease. And this is just an example where on the T2 weighted sequence within the piriform lobe, we see this T2 hyperintensity that's also present on FLAIR. And that region has contrast enhancement both within the parenchyma and meninges. And then after imaging, we often do CSF. And there's a number of different things that can be looked at and evaluated with CSF. Often inflammatory disease, we will see what's called pleocytosis with steroid-responsive meningitis and bacteria, often giving us the highest cell count. But this is not definitive. What's more important really than the cell count is going to be the differentials. So there's a number of different differentials with neutrophilic pleocytosis, the most common being bacterial or steroid-responsive meningitis arteritis, but you can also see it with Cryptococcus, aspergillosis, and FIP. With mononuclear pleocytosis, the most common cause is going to be GME, but you can see it with viral diseases, necrotizing encephalitis, and lymphoma as well. Mixed pleocytosis can be seen with infectious causes and non-infectious, so fungal rickettsia protozoal versus the most common GME. There's also what's known as histiocytosis, which can also be seen with a mixed cell pleocytosis. And then eosinophilic, again, the most common cause in our domestic dogs is going to be idiopathic. The most common breeds where that's seen is going to be Golden Retriever and Rottweiler, but it's becoming more and more common. The more commonly recognized, but you can also see it with Cryptococcus protozoal infection, prototheca, parasitic, so a number of different causes as well. Stressing the importance, again, to not jump to a diagnosis of immune-mediated disease. If you're lucky, you can see the organism. So on the left is an animal that has a protozoal infection. I believe it was a cat with toxoplasmosis. You can see the bradyzoite within the white blood cell. On the top right is an example of Cryptococcus, and on the bottom right is intracellular bacteria within the mononuclear cell. As far as going through the different forms of infectious diseases, that's where we're going to start. Going through viral, protozoal, fungal, tick-borne, and then bacterial. Remember that if you are suspicious of an infectious etiology, think about as far as a point of entry, and that could help narrow down the differentials. This is just an example of a patient that had a bite wound. So on the top right T2 weighted sequence, you can easily make out the calvarial defect, and then you can see the intraparenchymal hyperintensity. That can also be recognized on the flare on the top left. On the bottom is going to be our T1 weighted sequence in a different patient where we see extension of otitis media interna into the calvarium causing a focal meningitis. And then on the top right is another patient that had a bite wound and subsequent bacterial infection. Starting with our viral encephalitis, I'm just going to talk about the two most common. I'll bring up a couple at the end, but just to hit a couple highlights on those. So we'll talk about distemper and rabies. So distemper, it's a morbillivirus, and it's transmitted via aerosol, like most, if not all, morbilliviruses. And it will produce severe transitory immunosuppression initially. Canine distemper virus in ferrets is more severe than in dogs and leads to death, usually within 2 to 3 weeks of infection. The catarrhal phase of canine distemper virus involves anorexia, pyrexia, photosensitivity, and serosal nasal discharge. Mucopurulent oculonasal or ocular nasal discharge with possible bacterial pneumonia may be seen with a secondary bacterial infection, which resembles an influenza infection. The hard pad lesions on affected ferrets are usually not as pronounced as those on dogs, most likely because of the severe rapid progression and it being fatal most commonly in the ferret. This has not been reported in the domestic cats naturally, but it has been shown that it can be experimentally induced in cats. And they've actually shown that there can be canine distemper viral replication with pronounced lymphopenia in the cat, but they don't display any signs. In dogs, clinical signs we kind of already talked about, though not as severe as the ferret: pyrexia, anorexia, nasal discharge, conjunctivitis, diarrhea, and skin pustules with hyperkeratosis. Neurologic signs usually appear during the systemic phase of the disease, and if it does occur, it's usually the most common cause of death in animals with distemper. Right, so this is just a little bit more detail as far as the clinical signs and why they're occurring, so feel free to skip ahead if you don't want to hear this. So as stated earlier, under natural conditions of exposure, canine distemper virus is usually transmitted by aerosol and infects the upper respiratory tract. During the first 24 hours post-infection, viral replication occurs in macrophages and circulating B and T cells, and later on, viral particles spread through the lymphatic pathway to bronchial lymph nodes and tonsils. Primary viral replication in the lymphoid tissue leads to the lasting and severe immunosuppression. About 2 or 4 days after infection, there is an increased amount of viral particles in tonsils, as well as retropharyngeal and bronchial lymph nodes. However, there is a small number of infected mononuclear cells in other lymphoid organs. During the first 4 to 6 days post-infection, viral replication occurs in the lymphoid system, bone marrow, thymus, spleen, lymph nodes, mesenteric lymph nodes, Peyer's patches, stomach cells, Kupffer cells, and mononuclear cells. These are around the bronchial and pulmonary vessels. Then, between the 2nd and 6th days, hyperthermia is observed due to the high rate of viral multiplication in the lymphoid organs, as well as leukopenia caused by depletion of lymphoid cells. After viremia, about 8 to 10 days post-infection, canine distemper virus disseminates via hematogenous pathways to the cerebrospinal fluid, to several epithelial tissues, and the central nervous system. Infected lymphocytes infiltrated in the epithelium may locally release massive virus amounts, favoring epithelial cell entry and consequently respiratory, intestinal, and urinary infection. Infection of the CNS is the most serious complication of canine distemper, leading to a variety of neurological disorders, often with a bad prognosis. Neurologic signs can occur in the absence of systemic signs, and this is thought to be if it spreads from the CNS by the olfactory cells. Aspects such as the presence of antibodies and deposition of immune complexes, which occur during systemic immune response, can contribute to viral spread in the CNS endothelium. Both free and platelet or lymphocyte-bound viruses invade vascular endothelial cells in the meninges, choroid plexus of the fourth ventricle, and the ependymal cells in the ventricular system. Let's see. Moreover, frequent subpial and periventricular lesions associated with the fact that the virus is easily found in these cells of the choroid plexus and ependyma demonstrate that viral penetration in the brain tissue occurs mainly through the CSF. Astrocytes are considered the target cells for the canine distemper virus in the CNS, and they are related to the demyelinating lesions, which are very characteristic of acute and chronic encephalitis. Regarding viral dispersal in the CNS, it was observed that spread of CVD in astrocytes did not require infectious particles, and that viral spreads to neighboring cells may occur in very short intervals of time, introducing the idea about lateral transmission between cells in the brain to be highly efficient. Therefore, canine distemper virus might use gap junctions to spread to the astrocytes. This can be direct action of viral activity in the CNS, and this can cause acute encephalitis, which appears in the early stages of the infection in young or immunosuppressed animals. Canine distemper virus causes multifocal lesions in gray and white matter. Lesions in the gray matter include neuronal infection and necrosis and may lead to polioencephalomalacia. On the other hand, damage to the white matter are defined by myelinic lesions and are correlated with viral replication in glial cells. Whether there is a physiologic immaturity of the immune system or immunosuppression induced by the virus, inflammatory changes are minor. In most cases of spontaneous canine distemper, the virus causes multifocal lesions in gray and white matter to the CNS. Usually demyelinating lesions prevail, and lesions in the gray matter are absent. Preferential sites are the cerebellum and periventricular white matters, especially around the fourth ventricle, optical pathways, and spinal cord. Canine distemper virus reaches the brain through infected mononuclear cells that cross the blood-brain barrier. Another more important possibility to be considered is the fact that canine distemper virus can also reach the central nervous system via circulation in the cerebrospinal fluid and associates with the ependyma that coats the ventricles. This explains the frequent periventricular and subpial location of the lesions. And this is just an image summarizing everything I just said. Here's an example of a neurologic lesion. And we can see that there is eosinophilic neuronal necrosis that is occurring. There's adelatosis as well, and intranuclear inclusion bodies. A rare outcome of canine distemper virus is chronic encephalomyelitis of mature dogs, termed old dog encephalitis. Old dog encephalitis presents as a progressive cortical derangement with a wide range of clinical signs and usually occurs in dogs with a complete vaccination history. Frequent lesions associated with old dog encephalitis are multifocal perivascular and parenchymal lymphoplasmacytic encephalitis in the cerebral hemispheres. The disease seems to develop in dogs after acute canine distemper virus infection when the virus gains the capacity to persist in the nervous tissues. Diagnosis, usually not definitive, but you can get a pretty good idea based on a number of different things. So if you have CNS signs along with pyrexia, respiratory signs, conjunctivitis, and hyperkeratosis, if there's multifocal CNS signs with a myoclonus, that can also be indicative. If you have a CSF with cytoalbuminologic disassociation, and you can also screen for the distemper DNA using a PCR, either the urine or the CSF. Treatment is nonspecific with supportive care, and prognosis is generally poor. Next, we'll talk about the rabies. The rabies virus is the prototype of the genus Lyssavirus in the family of the Rhabdoviridae. The agents are enveloped, bullet-shaped RNA viruses, and it can affect all warm-blooded animals, but it's only been reported in mammals. So high risk of infection. for skunks, raccoons, bats, rabbits, and cattle. Moderate infections in dogs, cats, goats, horses, and non-human primates. So the only animal that has a high risk of infection is going to be the cattle, which is interesting compared to the other domestic animals. Opossums and birds are thought to be at a low risk of getting infection, again with birds never being reported, but it's thought to be possible. Cats are somewhere between low and moderate risk of infection, and the young are more susceptible than the old. Transmission is through the bite of an animal with the rabies virus within the saliva. The most common cause of rabies in people is going to be from dog bites, and the most common cause of rabies in people in the United States is going to be from bats. In extreme conditions, you can actually catch it from an aerosolized route, and this has really only been reported in bat caves. You could also get it if there's transplacental infection, and this is thought to be from the more high-risk animals, so skunk, bat, and cow. Or if you have ingestion of tissues or secretions, and especially if you have wounds within your mouth. The incubation period is influenced by the age of the bitten individual, the degree of innervation of the bite sites, the distance from the point of inoculation to the spinal cord or brain, the variant and amount of virus introduced, post-exposure prophylaxis, and other factors. The virus may be undetectable in local tissues following the bite, and it does not enter the blood. Rabies is unique in that the incubation period, which is relatively prolonged compared to that of other infectious diseases, is primarily a result of route of the virus entry into and spread within the central nervous system. After intramuscular inoculation, virus may enter peripheral nerves directly or replicate locally in non-nervous tissue. Virus may enter neuromuscular junctions and nerve spindles after a variable period of days to weeks to months. Rabies virus glycoprotein has homology to certain neurotoxins and attach to axon terminals through lipoprotein receptors. Included in those is acetylcholine. Virus spreads passively by intraaxonal flow in peripheral nerves at a rate of about 100 millimeters per day, so 10 centimeters per day. Both motor and sensory fibers may transport the virus. The greater the degree of innervation at the site of the bite, the shorter the incubation period. In naturally occurring cases of rabies, ranges of incubation periods before CNS signs have been reported to be an average of 3 to 8 weeks in the dog, 4 to 6 weeks in the cat, and 3 weeks to 1 year in people. The virus enters the spinal cord or brainstem ipsilateral to the site of initial virus inoculation by retrograde axonoplasmic flow. Once in the CNS, virus spreads via intraaxonal means to involve the contralateral neurons and ascends rapidly and bilaterally in the spinal cord or the brainstem to the forebrain. Damage to the motor neurons causes progressive lower motor neuron signs, which in turn produces the typical ascending flaccid paralysis of rabies. Damage to the CNS caused by the rabies virus has been mainly attributed to direct virus invasion of the nervous system. Damage of neural tissue is visibly limited for the degree of paralysis. Inhibition of function or synthesis of neuronal transmitter is suspected. Apoptosis or genetically induced premature cell death may be important in the limited amount of observed neuronal necrosis. In other words, the clinical signs don't fit the degree of pathologic changes. Host immune response to rabies virus may accentuate the inflammation and degeneration of nervous tissue. Interference with cardiorespiratory control often results in the death. As far as the clinical signs, they can be thought of in three different aspects. There's the prodromal stage, then you can either get the furious stage or the paralytic stage, or potentially both. During the prodromal phase in dogs, which usually lasts 2 to 3 days, apprehension, nervousness, anxiety, solitude, and variable fever may be noted. Friendly animals may become shy or irritable and may snap, whereas fractious ones may become more docile or affectionate. Pupillary dilation with or without sluggish palpebral or corneal reflexes may become apparent. Most animals will constantly lick the site of viral inoculation. Some dogs may develop pruritus at the site of exposure and claw or chew at the area until it's ulcerated. The behavior of cats during the prodromal period is similar to that of dogs. However, cats more typically show fever spikes and unusual or erratic, typically aggressive behavior for only 1 to 2 days. The furious or psychotic type of the disease in dogs usually lasts for 1 to 7 days and is associated with forebrain involvement. Animals become restless and irritable and have increased response to auditory or visual stimuli. They frequently become excitable, photophobic, and hyperesthetic, and bark or snap at imaginary objects. As they become more restless, they begin to roam, usually becoming more irritable and vicious. Dogs may eat unusual objects, this is known as pica, especially wood, that become gastrointestinal foreign bodies. They may avoid contact with people and prefer to hide in dark or quiet places. When caged or confined, dogs often try to bite or attack their enclosure. They usually develop muscular coordination, disorientation, and generalized tonic-clonic seizures during this phase. If they do not die during a seizure, they may experience a short paralytic stage and then die. Cats may develop more consistently the furious phase of this disease, showing erratic and unusual behavior. These cats are described as having anxious, staring, wild, spooky, or blank looks in their eyes. When confined to cages, they may make vicious, striking movements and attempt to bite or scratch at moving objects. In addition, they may have muscular tremors or weakness or incoordination. Some cats may run continuously until they seem to die of actual exhaustion. The paralytic or dumb type of rabies usually develops within 2 to 4 days after the first clinical signs are noted. Lower motor neuron paralysis usually progresses from the site of injury until it enters the CNS. Cranial nerve paralysis may be first recognized for this type of clinical syndrome if the bite does occur on the face. When the brainstem becomes affected, a change in the tone of bark resulting from laryngeal paralysis may be observed. Dogs, which more commonly show this type of disease, may begin to salivate or froth excessively as a result of the inability to swallow and the deep labored respiration that occurs. A dropped jaw develops as a result of paralysis of the masticatory muscles. Dogs may make a choking sound, which convinces the owner that something is caught in the animal's throat. Owners or veterinarians may then become exposed to the virus in the saliva while attempting to remove a suspected foreign body. The course of the paralytic phase usually lasts 2 to 4 days. The animal often goes into a coma and then dies of respiratory failure. Rabies is more inflammatory compared to distemper. Perivascular lymphocyte-rich exudate is seen around blood vessels. And here at the arrow, you can see a necrotic neuron. Occasionally, there are activated microglia, and they can be seen phagocytizing the neurons, process termed neuronal phagia. And this is a IBA1 immunostain. And then we can see the cytoplasmic nacre bodies as shown by the arrows here. Acute polioencephalitis characterized by minimal neuronal phagia, neuronal degeneration, and non-separative inflammation is seen very early in the course of the disease Necrotizing encephalitis is seen in the next phase of infection and corresponds to a gradually increasing titer in the serum and CSF. Chronic infections are characterized by focal or widespread lymphocytic and plasmacytic perivascular cuffing and focal mononuclear cell infiltrates in the CNS. Ganglioneuritis is usually present. The longer the course of illness, the more pronounced is the non-suppurative inflammation response in the brain and the spinal cord. In some cats, spongiform lesions appear as vacuolization in the neuropil of the gray matter, most commonly in the thalamus and the inner layers of the cerebral cortex. The direct fluorescent antibody for the antigen detects the rabies, and it's very sensitive. Lastly, I'll talk about some of the emerging viral encephalitides, the dog and the cat. So the carnivores thought to be a dead-end host with these, but they are being reported potentially with more frequency. So there's West Nile virus, the hemiparaviruses, H5N1 avian influenza, and then the Bornaviruses, more so in Europe. Next, I'll talk about the protozoal encephalitides, the two most common being toxoplasmosis and Neospora in the dog and cat. Toxoplasmosis is an infectious condition caused by the protozoal Toxoplasmosis gondii and occurs in acquired and congenital forms in man and animals. Cats are the definitive hosts for this parasite. The three known infectious stages of toxoplasmosis are the bradyzoites, tachyzoites, and sporozoites. The three modes of transmission are ingestion of the bradyzoite, if there's fecal contamination, and then also in utero infection. These modes of transmission involve the different infectious stages as follows. Carnivorous ingestion of encysted bradyzoites, tachyzoites, or both. Contamination with feline feces containing the sporozoites of sporulated oocysts. Transplacental infection of the fetus with tachyzoites, or ingestion of encysted bradyzoites or sporulated oocysts by the mother. Humans, sheep, pigs, dogs, and rarely cats are known to transmit Toxoplasma gondii transplacentally. In humans, congenital infection occurs when a woman becomes infected during pregnancy. Toxoplasma oocysts are shed in feline feces unsporulated and are not infective until sporulated. This usually occurs within 1 to 5 days. Sporulated oocysts can survive in the soil for several months. Land snails, earthworms, flies, and cockroaches may serve as transport hosts for oocysts. Most mammals become intermediate hosts through ingestion of oocysts. Following the acute systemic infection in intermediate host in which the organism can be disseminated to many body organs, this phase may be subclinical. Tissue cysts form, most commonly in the CNS, skeletal muscles, and heart. This conversion is related to development of the host humoral and cellular immune response. The parasites are mainly intracellular, and subclinical infection may persist for the life of the host. Activation of toxoplasmosis may occur in association with severe immunosuppressive disorder. This condition is often associated with canine distemper or infections such as Ehrlichia, or if there's glucocorticoid therapy. Clinical toxoplasmosis is most commonly seen in young dogs less than 1 year of age or in immunocompromised older dogs. Many disorders previously ascribed to toxoplasmosis in dogs have now been found to actually be neosporosis caused by Neospora caninum, an apicomplexan protozoal parasite that can infect puppies in the neonatal period. Dogs are the only proven definitive host for Neospora caninum. Its life cycle is unknown, although transplacental transmission has been shown in dogs. It has a wide range of hosts, but its zoonotic potential is unknown. Older dogs may also be affected. Fatal neosporosis has been documented throughout the world, and Neospora caninum has been isolated in the USA and several European countries. Toxoplasmosis in dogs resulting in systemic infection will typically affect most organs, and the CNS in particular. Neurologic signs associated with toxoplasmosis or neosporosis encephalomyelitis are variable and may reflect a focal or multifocal disease process. In dogs, signs include hyperexcitability, depression, intention tremors, paresis, paralysis, head tilt, and seizures. In the diagnosis of toxoplasmosis neospora neurologic infection, abnormal hematologic parameters may include non-regenerative anemia, a neutrophilic lymphocytosis or leukocytosis, a lymphocytosis, or eosinophilia. Serum ATP or AST may be increased, especially in dogs with acute hepatic and muscular necrosis. Results of CSF may be abnormal. There could be elevated protein or a mixed mononuclear polymorphic nuclear pleocytosis. An eosinophilic pleocytosis has been found in dogs with granulomatous encephalomyelitis due to protozoal infection. Xanthochromia may be present if hemorrhage has occurred. Electromyographic tests may reveal fibrillation potentials, positive sharp waves, bizarre high-frequency potentials, and myototic-like discharges. Nerve conduction velocities may also be decreased. Serum CK levels are often increased. Protozoal and meningoencephalitis has been detected using MRI scans. They closely resemble that of toxoplasmosis. The Toxoplasma and Neospora caninum tachyzoites and tissue cysts have been used for diagnosis on histopathology, and clinical syndromes appear to be identical. Differentiation between the two protozoal organisms can be made using assays for circulating antibodies by tissue immunohistochemistry and ultrasonic or ultrastructural studies. Sensitive PCR assays have been reported for the detection of Neospora caninum and toxoplasmosis DNA in biological samples. In general, neosporosis is asymptomatic in older and adult dogs. More severe and frequent infection occurs in younger dogs, usually less than 6 months of age. The clinical signs are usually general and the same as toxoplasmosis, but neurologic and muscular abnormalities can predominate, such as paralysis. In younger puppies, so 3 to 9 weeks of age, it's not uncommon to actually see atrophy within the limbs that can result in muscular rigidity, and this can often be the most important clinical signs and used to differentiate neosporosis from other disorders causing paralysis. The paralysis progresses to rigid contracture of the muscle from the affected limb. This arthrogryposis results in scar formation in these muscles due to the injury of the lower motor neuron and myositis. Articular deformation and joint curvature, so genu recumbatum, can occur in some puppies, followed by cervical weakness, dysphagia, megaesophagus, and death from respiratory signs. Dogs remain in an alert status, paralyzed, and require special care for months. In addition, severe diarrhea and incoordination, multifocal pulmonary consolidation with necrotic and purulent bronchopneumonia, fibrinohemorrhagic enteritis, myocarditis, and non-purulent encephalitis can occur in young puppies. It is more probable that dogs over 6 months old can develop the disease by a reactivation of a latent chronic infection. Adult dogs typically develop polymyositis or meningoencephalomyelitis with clinical signs related to multifocal lesions in the CNS, mainly in the cerebellum. On the other hand, myocarditis, dermatitis, pneumonia, diffuse peritonitis with peritoneal effusion, and multifocal dissemination can occur, but are less common as a result of tachyzoite dissemination. These dogs may be obtunded and develop ataxia, circling, head tilt, nystagmus, hypermetria, head tremors, delayed placement reactions, abnormal cranial nerve function, anisocoria, depressed segmental reflexes, tetraparesis, cervical hyperesthesia, and seizures. In the chronic stage, most animals remain asymptomatic. However, females may have immunosuppression and reactivate the infection during gestation. In this way, bradyzoites switch back to the tachyzoites, cross the placenta, and affect the fetus. In buffaloes, naturally occurring disease is rare, but abortion has been reported in animals that have contact with dogs, up to 60%, which highlights the role of dogs in the epidemiologic chain of neosporosis in production animals. Neosporosis should be considered when hyperesthesia, muscle swelling, or atrophy is observed at the clinical exam. Focal lesions have been reported in the brain and spinal cord. Necrotizing cerebrolitis and hepatitis have also been observed. For the diagnosis, there's really nonspecific findings that are listed there. As far as the direct methods, you can actually visualize oocyst. This can be within the feces themselves. So if you do a fecal flotation, you could do tissue cysts as well, or see tachyzoites within the tissue cysts. You can also do PCR. And then the indirect method is going to be with serology, in which you're going to see a fourfold increase in the IgG titers within 15 to 30 days. Treatment of neosporosis is usually difficult and temporary, partially or completely ineffective. Long periods, 8 weeks of treatments, may be required. In puppies, the treatment for dogs with neurologic signs is often long and has a poor prognosis. Treatment is most effective in early stages before muscular contracture has occurred. Clindamycin is the primary used to treat canine neosporosis, and it's the only lincosamide that possesses additional antiprotozoal activity. Therefore, it is effective against neosporosis tachyzoites. The combination of clindamycin and sulfonamide is highly effective against neosporosis. In addition, the synergistic effect of sulfonamides and permethamine enhances antiprotozoal effects. Clindamycin affects the multiplication of Neosporosa caninum tachyzoites, but is thought to have little or no effect on the bradyzoites. In this way, tissue cysts may persist even after 2 months of treatment. Usually, most of the protocols used to treat neosporosis focuses on control of the clinical manifestation rather than the parasitological cure. So, although not that common, we'll next cover the mycotic encephalitides. Mycotic infection is dependent on the location of the animal, as certain infections are only going to be, or certain mycotic organisms are only going to be in certain parts of the world or United States. Fungal infection more often occurs in younger animals spending more time outdoors, or strangely in larger breed dogs. Young German Shepherds are overrepresented for aspergillosis. However, indoor-only cats have also been reported to have mycoses. Disease also occurs in older animals, including CNS cryptosporosis in cats and many cases of solitary CNS granulomas. Exposure to bird or bat feces sitting on soil, including in houseplants, is pertinent. Geographic location and travel history are also critical. Cryptococcus neoformans is worldwide, but Cryptococcus gattai is common around the Vancouver Islands and northwestern United States, but is now recognized as a distinct species to Cryptococcus neoformans. Most coccidioidomycosis cases are in animals that live in Arizona's and neighboring states, or in animals that live there for up to 6 years previously. Many blastomycosis cases are in the Midwest, Ohio, and Mississippi River valleys, or certain other clusters. Proximity to bodies of waters are also risk factors to dogs. Most histoplasmosis cases are associated with the Mississippi, Ohio, or Missouri River valleys. Many CNS mycoses cases have progressive neurologic signs over 0 to 14 days. Transitory steroid responsiveness is common. Longer neurologic histories occur, especially with Cryptococcus. Neurologic clinical signs depend on location, obviously. With multifocal meningoencephalomyelitis, forebrain and centrovestibular deficits are common. In sinonasal mycosis with intracranial extension, seizures and other forebrain deficits are typical. With a solitary CNS granuloma, neurolocalization is often focal or forebrain or spinal. A cerebral mass with brain herniation may cause diffuse intracranial deficits. Cases with ventriculitis often have rapidly progressive brainstem disease. When present, systemic signs generally precede the neurologic signs, but can occur concurrently. Systemic clinical signs are often present for days or a few weeks. However, cats with CNS cryptococcus had extended extraneural histories, so a median of 52 days and up to 4 years in some cases, which was significantly longer than that of dogs, which was median of 7 days. There may be no clinical evidence of extraneural involvement as well. Specifics regarding extraneural disease will be discussed later. First, we'll start with multifocal meningoencephalomyelitis, which is especially common with hematogenous brain infections of Cryptococcus. Small animal CNS Cryptococcus is frequently forebrain or multifocal in character. The pathogens are Cryptococcus neoformans, especially in dogs, and Cryptococcus gattai, especially in cats. Cats develop Cryptococcus more frequently, but dogs have more CNS involvement. The incidence of CNS mycoses is broadly similar. Canine aspergillosis cases may involve a combination of azotemia, osteomyelitis, lymphadenopathy, and meningoencephalitis. Aspergillosis tertius is most common, and rarely is there a nasal mass involving the brain, and that will be discussed later. One variation of blastomycosis is multifocal brain disease without sinonasal lesions and localizes to the forebrain. Histoplasma can cause diarrhea, multisystemic disease, and meningoencephalitis, including seizures, vestibular syndrome, and organisms in the CSF. The major differential diagnosis for nasal mass lesions and cribriform plate destruction are neoplasia and mycoses. The typical case in a dog or cat with a history of nasal discharge, epistaxis, or sneezing for 2 weeks to 1 year without systemic mycosis. Thoracic radiographs are often normal. Lesions within the frontal olfactory region and seizures are classic. Cribriform plate penetration is also detected during rhinitis workup in neurologically normal dogs. This is most common with blasto, but also occurs with crypto and aspergillosis. With cryptal, nasal and intracranial lesions occur without cribriform plate destruction. Aspergillosis fumigatus is a leading cause of fungal rhinitis in oligocephalic dogs, especially when nasal planum depigmentation is seen. Ventriculitis is well documented in canine blastomycosis. It may emerge in other mycoses. A hallmark is obstructive hydrocephalus and rapid neurologic decline. Fungal dissemination through the CSF probably follows hematogenous brain infection, meaning systemic disease is common. A single granuloma on advanced imaging may occur in one of 2 settings, and in either situation can be mistaken for neoplasia. The pigmented hyphae organism, Cladophyllophora bantiana, is neurotrophic and can form an intracranial granuloma without extracranial involvement. Systemic mycoses, including coccidioides, can form a mass-like granuloma with variable extraneural disease. Serology is not available for the Cladophyllophora. Known for intracranial infection without systemic disease, antemortem diagnosis may only be possible through surgical excisional biopsy or minimally invasive biopsy. Coccidioid granulomas occur in various sites along the neural axis, especially in the frontal lobe or spinal cord. Other presentations of blastomycoses and cryptococcus discussed earlier are more common, but solitary CNS granulomas do occur. There is diagnostic utility in knowing the typical systemic presentation of fungal organisms. So in cats, There's usually an associated nasal infection, 52% of them, cutaneous in 45%, and 32% have ocular lesion. In dogs, it's listed here, neurologic clinical signs occur in about 61% of dogs, and more common than what's seen in cats. And then about 45% will have ocular signs. And then nasal clinical signs occur in about 19% of dogs. Canine blastomycosis involves the respiratory system in the majority of cases, 88% of the time, lymphatic 67% of the time, and ocular 52% of the time. In coccidiomycosis in dogs, pneumonia classically occurs first, whereas osteomyelitis indicates dissemination. In cats, dermatologic and disseminated infections predominate with coccidiomycosis. Aspergillosis fumigatus is the foremost cause of canine mycotic rhinosinusitis, whereas Aspergillosis terreus causes discospondylitis or disseminated disease, but rarely rhinitis. Systemic signs minimum database and thoracic radiographs often do, unfortunately, have variable findings. Cryptococcal organisms are identified in the CSF of most dogs and even more so in cats. However, the organisms are observed only sporadically. Fungal culture in the CSF is often negative, but there are some cases where it can be positive. As discussed earlier, neurosurgery or minimally invasive biopsy achieves definitive diagnosis for most CNS granulomas. Serologic testing is shown above as a reference. Urine antigen for what's known as galactomannan for blastomycosis is considered the best for sensitivity and specificity. It is typically used as it has cross-reactivity for histoplasmosis, and both are thought to be sensitive and specific. For coccidioides, serum enzyme immunoassay antibodies are considered the most sensitive and specific. Latex cryptococcal antigen testing is thought to have a high sensitivity and specificity for both dogs and cats, and CSF can also be used. For patients suffering from aspergillosis with systemic disease, antigen testing is thought to be sensitive and specific, but with localized disease, the results are often disappointing. The beta-D-glucan assay can be positive for any fungus except Cryptococcus and Blasto, but it has not been evaluated in dogs. CNS involvement is a negative prognostic indicator for mycoses, and in neurologic Cryptococcus, altered mental status further decreases the prognosis. The CNS is a difficult location to treat effectively. This difficulty relates to the blood-brain barrier and blood-CSF barrier. The presence of efflux pumps associated within the blood-brain barrier makes it impossible for some drugs to reach effective therapeutic levels within the CNS. The efficacy of antifungal medications depends on several factors: the fungal pathogen being treated, the susceptibility of the pathogen to therapeutics, the location of the pathogen within the CNS, and the ability of the drug to reach the pathogen. The table shows the 5 main classes of antifungal medications. There's the polyiene antibiotics, the azoles, the cytosine analogs, the allylamines, and the glucan synthesis inhibitors. Some of these antifungal medications are more readily used in veterinary medicine than others. The difference in use is related to availability, safety, cost, and efficacy in veterinary species. In general, an azole that penetrates the blood-brain barrier is used, such as fluconazole or voriconazole. Voriconazole is neurotoxic to cats. Ketoconazole and itraconazole mainstays in extraneural mycoses are poor choices, except perhaps with extradural masses. Combination therapy may be appropriate, such as flucytosine or amphotericin. Liposomal or lipid complex amphotericin B formulations show improved CNS penetration and reduce nephrotoxicity. Prolonged duration of treatment is indicated. Ideally, the response of treatment is followed for, by example, serial antigen quantification or MRI and CSF, which is highly beneficial when considering medication discontinuation. Microbiologic cure may profoundly lag behind clinical cure. Judicious short-term use of corticosteroids may be beneficial when provided with meticulous supportive care. Survival in the first 10 days was significantly increased in patients that received corticosteroids. Patients may deteriorate when fungicidal therapy is started, then improved with co-administration of anti-inflammatory corticosteroids. It is thought that fungal die-off increases CNS inflammation. There is evidence in various species, especially in humans, that surgery improves outcome for fungal CNS granuloma. These are the most common tick-borne diseases diagnosed in dogs. Recall that A. platus infects platelets, therefore it will not directly cause CNS disease. Based on the best evidence we have in the United States, A. phagocytophilum and Borrelia burgdorferi do not cause CNS disease in dogs. E. canis has been reported in a number of cases in dogs with meningoencephalitis. In the majority of these cases, morula can be seen in macrophages. However, on occasion, it can be seen in eosinophils as shown in the image and what the black arrow is pointing to. Rocky Mountain spotted fever is the most common cause of tick-borne CNS disease in dogs, with vestibular signs being the most common sign seen. R. rickettsia infects endothelial cell and is generally not just localized to the CNS. The diagnosis of Rocky Mountain spotted fever is supported by compatible clinical signs, compatible laboratory abnormalities, including thrombocytopenia, hypoalbuminemia, and leukocytosis, elevated serum antibodies to R. rickettsia, and a response to treatment with doxycycline. Bacterial encephalitis is uncommon but well described. The most common routes of bacterial infection into the CNS are hematogenous, resulting from mucosal membrane colonization or distant pyogenic focus. They can be direct invasions, such as with a dog bite or traumatic injury, or contiguous effect, such as with an inner ear infection, nasal sinus infection, or vertebral osteomyelitis. It can also be via communication with CSF and body surfaces. Hematogenous infection most commonly localizes in the region supplied by the middle cerebral artery, which include the choroid plexus of the lateral ventricles and the capillaries of the cerebral cortex. Septic cerebral emboli from chronic lung infections and direct extension from middle ear or sinus infections are usually responsible for polymicrobial infections. Bacterial infections of the CNS can rapidly disseminate and lead to serious illness or death. Common clinical signs are shown here. The most common bacteria associated with meningitis, or the bacteria associated with meningitis or meningoencephalitis in dogs, is Staphylococcus, followed by Pasteurella, Nocardia, Actinomyces, and various anaerobic species. Prognosis is thought to be poor, with only one study discussing survival after diagnosis, which was 0 to 42 days. Subdural empyema, or abscess, is even more rare than bacterial meningitis. I can only find 7 case reports in veterinary medicine. Cultures from subdural empyema in prior veterinary case reports commonly found polymicrobial infections with at least one anaerobic bacterium, such as Fusobacterium, Bacteroides, Actinomyces. Gram-negative infections are actually rare. Common sources of infection in either meningitis or meningoencephalitis are similar to those implicated in subdural empyema and include otitis interna, tooth root abscess, retrobulbar abscess, and sinusitis. However, hematogenic spread from extracranial sources such as endocarditis, pneumonia, prostatitis have all been reported. Prognosis is considered poor without surgery in people, but evidence is limited in dogs. Presentation and pathogenesis, so spinal empyema, is defined as an extensive accumulation of purulent material in the epidural space of the vertebral canal. This is an uncommon condition, also reported in humans after spinal epidural anesthesia, spinal surgery, or hematogenous spread. Direct extension of osteomyelitis is another cause of the infection. Characteristic clinical signs are a high fever, acute progressive spinal hyperesthesia, and progressive myelopathy. For diagnosis, hematology reveals an inflammatory leukogram. Blood cultures can be positive. Staphylococcus and Streptococcus species are the most common isolates. Radiography may reveal vertebral fasciitis or discospondylitis. Extensive epidural lesions have been identified on myelography. For the treatment, effective treatment is rapid institution of appropriate antibiotic therapy or surgical drainage of the epidural fluid. The prognosis is considered guarded. The length of time the patient has been non-ambulatory before antibiotic therapy is instituted is inversely proportional to neurologic recovery. Neuroleptospirosis has been reported, leading to clinical signs in cattle and swine, but it has not been reported in the dog or the cat. In severe cases, it can lead to a vasculitis resulting in secondary CNS signs, but it's not thought to be related to direct CNS infection. Neuroleptospirosis is also well documented in people. When it comes to treatment, remember that penetration of the blood-brain barrier is important. It might not be as important in the initial phase of treatment, though. Finally, I'll talk about the non-infectious form. So this is going to be the most common. GME can be multifocal or disseminated. Then there's focal forms and ocular. GME may represent up to 25% of all canine inflammatory CNS diseases. Neurologic signs of GME are nonspecific and can be localized to forebrain, brainstem, spinal cord, or appear as multifocal syndrome. The clinical presentation correlates with 3 pathologic distributions, as I discussed. Multifocal GME typically is characterized clinically by acute onset and rapid progression of multifocal neurologic signs. In the acute phase, dogs may have a fever and exhibit paraspinal hyperesthesia, especially localizing to the cervical region. By contrast, focal GME tends to have more insidious or slow progressive neurologic signs and may suggest a space-occupying lesion. Forebrain and brainstem signs are reported most frequently with multifocal GME, whereas forebrain signs alone are more common with focal GME. The third form, ocular GME, clinically manifests as acute signs of visual dysfunction attributed to optic neuritis and sometimes considered one aspect of disseminated GME. Anterior and posterior uveitis can also occur. GME is a distinct pathologic entity in which neuropathologic lesions consist of whirling perivascular disseminated or focal infiltrates of mononuclear cells in white matter and meninges of the brain and spinal cord. It appears that in acute progressive disease, the gray and white matter is equally affected, whereas in more chronic GME, white matter is predominantly involved. It has been suggested, based on predominance of MHC class II and CD3 T cells, that GME is a result of delayed type hypersensitivity. However, CD3 immunoreactivity varies between GME and NME, or between GME and CNS histiocytosis. Necrotizing encephalitis is a subtype of meningoencephalitis of unknown origin that appears histopathologically distinct from GME because of characteristic necrotic lesions in cerebral white matter or gray matter. The onset of neurologic signs with necrotizing encephalitis ranges from 6 months to 7 years of age, but most commonly occurs in younger dogs with a mean age of 2.5 years. In general, signs associated with necrotizing encephalitis are rapidly progressive and commonly include seizures, abnormal mentation, vestibulocerebellar dysfunction, central visual deficits, and death. Histology typical of the necrotizing encephalitides includes non-separative meningoencephalitis and bilaterally asymmetrical cerebral necrosis. There are two subtypes of this category of lesion, namely the necrotizing meningoencephalitis and the necrotizing leukoencephalitis, which appears to have considerable overlap in breed association and lesion distribution. Necrotizing meningoencephalitis was originally reported as a breed-specific disease in pug dogs, known as pug dog encephalitis, and many other reports have followed. Necrotizing meningoencephalitis has also been reported in the Maltese, Chihuahuas, Pekingese, Westies, Papillons, Shih Tzus, Coton de Tuileries, Brussels Griffon, and other breeds. Dogs with necrotizing meningoencephalitis commonly manifest as forebrain signs, especially seizures, because of lesions within the cerebral cortex. Other forebrain signs include lethargy, anorexia, central blindness, circling, and head pressing. Cervical spinal hyperesthesia may be evident depending on the extent of the leptomeningitis. The hallmark of NME is extensive necrosis, which varies in severity from neuronal necrosis and gliosis in the early stages to gross cavitations and parenchyma in advanced disease. Lesions dominated by plasma cells, lymphocytes, and histiocytes commonly involve the leptomeninges, cerebral cortex, corona radiata, and subcortical white matter, and lead to loss of demarcation between the gray and the white matter. Lesions are most common in the cerebrum, but have been identified in the brainstem and cerebellum of pugs and other breeds. A distinctive segmental multifocal pattern of intense meningitis and encephalitis is a consistent finding in Chihuahuas, Maltese, and pugs. Park and colleagues divided the histopathologic lesions of NME dogs into three phases: mild inflammatory cell infiltration in the acute phase, moderate malacic changes, and intense inflammatory reactions, especially in the leptomeninges in the subacute phase, and extensive malacia in the chronic phase. Lesion topography also includes extensive leptomeningeal inflammation. Immunohistochemistry studies of lesions in a small cohort of dogs with NME suggest an IFN gamma can play a role in necrotizing meningoencephalitis. Necrotizing leukoencephalitis has been described in Yorkies and French bulldogs and differing clinical and topographic features. Clinically, most dogs with NLE will present with visual loss, seizures, and central vestibular signs reflecting forebrain and brainstem involvement. Histopathology of NLE is characterized by non-separative leukoencephalitis with multiple necrotizing foci affecting white matter of the forebrain and brainstem, with subsequent cavitary necrosis and predominant reactive gymnostic astrogliosis. It is noteworthy that leptomeningeal involvement usually is minimal, in contrast to NME. Neurons within gray matter appear to be unaffected despite parenchymal inflammation. Areas of necrosis and cavitation in NLE are more extensive in comparison with NME, although the cavitation is less predominant in the brainstem and cerebellum. A recent report of NLE in French bulldogs described inflammatory changes in optic nerves and retina, and one case reported described similar lesions in the spinal cord. T-cell response was associated with a marked upregulation of MHC class II expression, and that resident activated microglia cells rather than blood-derived macrophages play a central role in antigen-presenting and phagocytic cells in necrotizing leukoencephalitis of French bulldogs. Similarly to GME, these findings are suggestive of local antigen presentation and possible immune-mediated inflammation. However, these findings differ from those in GME in which macrophages represent the dominant cell type of infiltrative lesions. MUO is a clinical diagnosis based on neurologic examination, cross-sectional image findings, and CSF abnormalities, supplemented by exclusion of infectious diseases. For this reason, there is no specific non-invasive antemortem diagnostic test, and many other diseases can mimic MUOs. definitive diagnosis of non-infectious inflammatory CNS disease requires histopathology. However, Granger and colleagues used meta-analysis to formulate guidelines for establishing a presumptive diagnosis of MUO in the absence of histopathologic diagnosis. To summarize, dogs diagnosed with MUO have multifocal neurologic signs, CSF mononuclear pleocytosis, and hyperintense lesions on T2-weighted magnetic resonance imaging. Although some MRI features are common with the necrotizing and granulomatous forms, none are considered specific for the diagnosis of any disease. Moreover, the diagnostic efficacy of both CSF analysis and MR imaging is incomplete because some cases lack abnormalities in one or the other test. Lamb and colleagues determined that approximately 25% of brain MR images of dogs with an inflammatory CSF revealed no abnormalities, emphasizing that a normal brain image does not rule out CNS inflammatory disease. In NME, greater than 90% of lymphocytes are present. Many autoimmune diseases are complex polygenetic traits whereby affected individuals inherit multiple genetic polymorphisms that contribute to disease susceptibility and consequently act with environmental factors to cause disease. Although strong familial inheritance was reported in pugs with NME, a simple Mendelian inheritance pattern could not be demonstrated. Along with the wide range of age of onset and variable clinical course, this finding suggests the possibility of genetic modifiers and other influences contributing to the disease phenotype. Genome-wide association studies identified CFA12 near the dog leukocyte antigen, the DLA, subsequently focused on the region containing the DLA, DRB1, DQA1, and DQB1 genes. Although the causative mutation has not been identified, fine mapping and candidate gene subsequent implicated linked allelic homogeneity in the risk of developing NME. Furthermore, it is possible to attain risk assessment for NME by sequencing only the DQB1 gene that is now being used as a susceptibility haplotype when in the homozygous state. Such findings strongly support the role of immune system in NME. The strong DLA class II association of NME in pugs resembles that of atypical virulent fulminant forms of the disease spectrum in human multiple sclerosis. Once infectious causes have been ruled out, the primary treatment of MUOs is immunosuppressive therapy with corticosteroids and other agents. Initial treatment begins with patient stabilization based on the severity of neurologic dysfunction, followed by maintenance therapy. If there are seizures, anticonvulsant therapy is required. Stabilization may necessitate supplemental oxygen for hypoxemia, crystalloid colloid support to maintain cerebral perfusion and control hypotension, and osmotic therapy, such as with mannitol or hypertonic saline, to reduce elevated intracranial pressure. Immunosuppression is central to the therapeutic management of MUO, despite the incompletely understood pathogenetic mechanisms or triggers. The rationale of immunosuppression for autoimmune disease is to induce disease remission through the inhibition of inflammation and modulation of lymphocyte function. The ultimate goal is to achieve disease remission while minimizing adverse events. Corticosteroids historically have been the first-line therapy for treatment of MUO. Often anti-inflammatory to immunosuppressive doses of corticosteroids are initiated until review of negative infectious disease testing and then increased to higher immunosuppressive doses for 2 to 4 weeks, after which the dose is gradually reduced or tapered every 4 weeks when clinical signs stabilize or improve. We will now run through some of the immunosuppressive medications and their mechanism of action, starting with glucocorticoids. Recall that for something to be called a steroid, it means that it has to have a basic structure, and from that structure you get the different types of steroids, such as glucocorticoids, mineralocorticoids, and anabolic steroids. So to talk about the mechanism of how glucocorticoids cause immunosuppression, there's kind of 7 different ways that are thought to be at least the main ways that it causes immunosuppression. So the purple that you see on the image is going to represent the glucocorticoid, and the glucocorticoid is going to bind to the glucocorticoid receptor within the cytoplasm. So this glucocorticoid receptor complex has multiple genomic effects, and this includes binding of pro-inflammatory gene transcription, and this will block the function of the transcription factors such as NF-kappa B, which the downstream effect leads to decrease of the FC receptor on the macrophages. In other ways, it causes transcriptional repression via binding to negative glucocorticoid response elements, the GRE, and targets genes, leading to decreases in responsiveness to antibody-sensitized cells and decreases antigen processing. A third way is through transcriptional activation via binding to positive glucocorticoid responsive elements. A fourth way is post-transcriptional modification via the expression of molecules such as MKP1 and TTP, leading to decreased antibody production in B cells. Glucocorticoids may also have rapid non-genomic effects via alternate pathways, including direct membrane effects, interaction of membrane glucocorticoid receptors, and can also affect the mitochondrial pathways. This ultimately leads to cell apoptosis of the T cells and thought to be the cause of lymphopenia in steroid use. The next drug we'll talk about is cytarabine arabinoside. To understand its function, we need to recall some fundamental biology. Recall how DNA differs from RNA. Yes, the nucleotide base is different in thiamine versus uracil, but the sugar portion is more important here in that RNA is ribose, whereas the deoxyribose part of DNA is different between the two, being that the second carbon has lost an oxygen. So now you know where the term deoxy comes from and the term DNA, but also looking at what it's made of, the nucleotide is composed of a phosphate group, the deoxyribose group, the base, which is either going to be a purine or a pyrimidine. The nucleotide, though, that I want to focus on now for cytosine is the pyrimidine. If you look at the structure of cytosine and compare that to cytarabine, you can see that the structure is largely similar, except that the second carbon on cytarabine is now oxygenated. The last thing we'll talk about is the cell cycle. So recall that the S phase is where DNA synthesis occurs. So after mitosis and during the G1 phase, the chromosome is not double-stranded until the S phase, where it replicates. It is during this process that cytarabine will be inserted into the DNA, ultimately leading to cell death. And the arabinose sugar does not allow for the rotation of DNA. This is why cytarabine is termed an antimetabolite and S-phase specific. Before we discuss cyclosporine, we will first discuss some of the physiology of T cells. Here is a cartoon representation of an antigen-presenting cell binding to a T cell receptor. This will then activate the T cells, which results in a cascade of reactions, and the end of which is a release of intracellular calcium ions. The released calcium ions bind to and activate calcineurin enzymes. The binding of the B subunit allows a conformational change that allows calcium calmodulin to bind to the inhibitory domain of calcineurin. This then allows the catalytic domain to function and dephosphorylate target proteins, in this case, nuclear factor of activated thymocytes, or NFAT. Once dephosphorylated, NFAT becomes activated, revealing the nuclearization sequence. NFAT then translocates to the nucleus and attaches to specific enhancer regions on DNA, triggering transcription of particular genes, where in T lymphocytes, NFAT regulates the expression of interleukin 2. An endogenous protein that we have not discussed yet is cyclophilin. This is where cyclosporine binds. The drug cyclophilin dimer binds extremely tight to calmodulin, and thus the dephosphorylated NFAT will remain, and thus the dephosphorylation of NFAT cannot occur, and therefore interleukin 2 will not be produced. There's a number of other immunosuppressant drugs, which I'm not going to get into right now, but I've listed how the mechanism of action works. This is by no means an exhaustive list. To quickly talk about steroid-responsive meningitis arteritis, this disease, when you see it's large breed young dogs with cervical hyperpathia with a possible waxing and waning course. They often will have a fever and can have nonspecific neutrophilia. The key diagnosis is neutrophilic pleocytosis in the CSF. This is fairly pathognomonic, although as discussed earlier, other infectious causes can cause this. This is just an example of what it can look like in the CSF, and you can also get a meningitis, which can be seen on post-contrast MRI. This here is just a list of a protocol that's been described by Lowry for steroid-responsive meningitis arteritis. What's important about steroid-responsive meningitis arteritis is there does seem to be elevation of IgA throughout the disease. But you can see the C-reactive protein will change as the patients go into remission. Remember the potential side effects that can occur with steroids. When we talked about certain drugs for infectious diseases, remember the drug penetration of the blood-brain barrier. This holds true for immunosuppressive therapy. Here's a more extensive list of immunosuppressive therapeutic agents available, along with dosages that have been described and the sources. Don't forget the common drug side effects that can occur. This is just an example of a protocol using cytarabine and rabinicide. These are listed therapeutic outcomes depending on the drug that was chosen, although this is a little bit outdated now. And these are some of the limitations of that study. And this is just a summary of what we talked about. I ended kind of quickly just because the last handful of slides were pretty straightforward.